Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
Alright guys, we're back this week, and as we discussed during our Entitled CO2 episode last week, we would be discussing BiPAP versus CPAP. And we have, I think, fittingly labeled this siblings, not twins, because I think a lot of us don't really understand when, what, and where for the two of these, especially since most of us really only have access to CPAP in the 911 setting for sure.
For sure.
So by the end of this episode, even with a brand new EMT, we want to make sure you guys can explain why you would choose CPAP versus BiPAP, not just that you did. So, yeah, let's get into it.
Right, so there are two airway problems that require two separate tools. So breathing has two jobs: oxygenation, which is getting oxygen into the blood, and then ventilation, which is getting CO2 out of the body. CPAP and BiPAP help with these in different ways.
It means that if they are anxious and working really hard and freaking out and panicking and grabbing everything, they need oxygen. If they start getting tired and sleepy and lethargic, they need ventilation.
Welcome to another episode of Life in Sirens. Today, as we've already said, we're going to be digging in to CPAP versus BiPAP. The sister-sibling wars. You can take that out.
Please don't take that out.
I'm leaving it.
So,
All right, so step-by-step physiology. So we talked about how there are two jobs of breathing, right? But we're going to start with the oxygenation. So your air is going to go in to the alveoli, which is your teensy little air sacs. Oxygen crosses into the blood, hemoglobin, and carries it around. And then this is going to show up on your SpO2 once it gets all the way into your capillaries. So now we're going to talk about ventilation, right? So cells make CO2 as waste. And then when your oxygen goes into your blood basically offloads CO2 at the same time. So it dumps CO2, picks up oxygen. Well, that CO2 gets dumped back into your lungs, and then you exhale that CO2 out. So this is going to show up as your end tidal or your partial arterial pressure of CO2. Basically, SpO2 is telling you what you have gotten into your body. CO2 is telling you what you get out of your body.
what about positive pressure? That's the whole point, right, of these devices? So normal breathing uses negative pressure. We know this. Your chest expands and air gets sucked in. Everyone take a deep breath. There you go. So that was negative pressure ventilation. CPAP and BiPAP, they use positive pressure, so we push air in from the outside instead of like sucking it in, if that makes sense.
Yep.
So that pressure is what keeps your alveoli from collapsing and opens any fluid-filled or floppy alveoli.
Little floppy
guys.
alveoli.
They're sad and they're tired.
Poor atelectasis.
Poor atelectasis. I mean, that could be a girl's name.
It could be. I was about to be like, Alexis, what?
Okay.
Who is she?
She's a troublemaker.
A big part of CPAP and BiPAP, and something we need to take into consideration, it can reduce our preload and afterload, but also help the heart, especially in like situations like pulmonary edema.
Yeah.
So choosing wisely is important, and which one we choose is even more important.
Right. And that's why in things like CPAP and BiPAP, you want to be cautious if your patient is hypotensive.
Absolutely.
And that is not a direct contraindication, but you do want to be cautious just because it can increase your interthoracic pressure, which can then decrease your preload and make them even more hypotensive.
Yeah. So now let's actually get into it. What is CPAP, what is it doing? Why would we choose like CPAP. What is her job?
Her job is to provide a constant positive pressure during both inhalation and exhalation. It does not change.
That sounds exhausting.
Exhausting. So it gives one constant pressure during both your inhalation and exhalation is the same pressure the whole time, aka constant. And this pressure is essentially like PEEP. So it keeps your alveoli open between breaths, and then it makes each breath more effective at getting oxygen in. So when would you want to use CPAP?
Definitely think pulmonary edema.
Right? So you're
For
trying to
sure.
fix oxygenation problems with your CPAP.
Absolutely.
Right? So pulmonary edema, hypoxic pneumonia, atelectasis, and then some COVID ARDS patients early on.
Yeah, I would still probably
Lean towards BiPAP. But if you catch them at the very beginning,
right.
it can be appropriate.
It's kind of so think of CPAP as like your nasal cannula, and then BiPAP as your non-rebreather.
Mhm.
Like it is it's a step for more complex lungs as a general rule.
Absolutely. I like to think of CPAP as, is there something in your way?
Yeah, I like that.
Right? Is there fluid? Is there gunk? Whatever it is there something in your way that's keeping you from getting oxygen in and air out?
And sometimes it's all you got.
CPAP is not very good at certain things. So it's not good at pushing big extra breaths in because it's that constant pressure. So whatever your pressure is in is also your pressure out. So you have to balance that correctly. It's not great at getting rid of built up CO2. Again, because your patient has to really exhale against that pressure, which
Yeah.
is good for popping things open, but not so great for getting huge amounts of volume out.
You know, when you're on one of those rides at the fair that just spins around and around and around, that's what I think CPAP.
Yes.
There's a lot of wind in your face, but it's really hard to take
Yes.
a breath
If you
out.
guys have ever been skydiving, that is CPAP.
Yeah.
It is really hard to take a breath in or out. It is so much air and so much force that you literally are like,
Yeah,
it's really
CPAP
difficult.
is basically just propping the door open.
Mm-hmm. And air just like,
Yeah, just get in there.
and CPAP is also not very good at helping a patient who is too tired to move air. And I
Yeah.
think that this is a really important point, is that it takes a lot of work to breathe with a CPAP, which you know if you've ever tried to put one on somebody and they've fought it or ripped it off.
And you can make them sicker
Mhm.
and
If they do
their
not have
entitle worse.
Yes, if your patient does not have enough energy to breathe with and like really work with the CPAP, it's not going to be super functional for them. So it's not going to breathe for them. It's going to help them breathe. And it's going to help them do the work. CPAP is scaffolding for collapsing lungs.
Yeah, it's just propping everything up.
So what about BiPAP?
So BiPAP it just depends too, like what devices you're using, but we'll kind of talk about how you would do settings and things like that for BiPAP. BiPAP is more adjustable,
Mm-hmm.
so we like her better. In my opinion, I'm going to reach for BiPAP before I reach for CPAP in most scenarios,
Yeah.
other than like pulmonary edema. So when we're looking at BiPAP, we need to break it into two different things, right? So it's not just continuous. I don't know why I said it like that. Continuous pressure. You get pressure differently with inhale and exhale. So for EPAP is your expiration. So you're still getting the positive pressure. Same idea as CPAP or PEEP. So EPAP is PEEP. Think of it that way.
Perfect.
It keeps your alveoli open and it helps you oxygenate. IPAP, this is what makes BiPAP different. IPAP is inspiratory positive pressure, so you're getting higher pressure during inhalation. And this is kind of like how we talked about CPAP being scaffolding. BiPAP is you're holding their hand the whole way.
Yep.
And it can reduce their exhaustion because they're really not doing much on their own.
Yes.
And you can adjust it based on your, end tidal and oxygenation and things like that. So it is pressure support the whole time, not just in one way like CPAP.
And if you guys have ever brought a patient into the ER on CPAP, because it's all you carry, and then they've immediately switched them to BiPAP,
It's not your fault.
and when you come back later and they're like snoozing on BiPAP, they're taking a nappy.
It's because it's comfy.
Yes, because the reason why is because they're getting that help, that increased flow on their inspiratory, but then they're also getting some positive pressure on the expiratory, but it's not as aggressive as your CPAP.
Yes.
So you don't have to fight it and like really work as hard as they do
and
with
it's
CPAP.
much better for like your COPDers and things like
Yes.
that, where they need to blow stuff off.
Yes, they need to get air out, but it gives them enough of that resistance so that they can prop things open too.
So if we raise our EPAP, think of that as like how we provide support for oxygenation, and then IPAP is how we support ventilation, so you are able to take more comfortable and complete breaths in and out. You're not just skydiving, as Jamie says.
Yeah, absolutely.
CPAP is a brace, and then BiPAP is like a brace and crutches.
Yes, it's both.
Like you get all the support.
Yeah.
Yes, and BiPAP is going to give you the power to inhale and then the purpose to exhale.
Yeah, because you are feeling like you should.
So who would you use it on?
Definitely, like we said, our COPDers, asthma patients, people who need to exhale.
Everybody but pulmonary edema.
Pretty much.
Almost.
Yeah, anyone that is tired and fatigued, they're still awake, they're still protecting their airway, but you can tell that they're losing steam. This is actually one that we don't talk about a whole lot, but obesity hypoventilation. Sometimes you have patients that positionally have a really hard time breathing, and it may be because they're morbidly obese, and the actual like pressure from the weight on their thoracic cavity makes it so that they cannot take a full deep breath.
And those extremely morbidly obese patients,
Mhm.
they may not even be, and think about this in more long distance transfers, but like they may not even have a respiratory issue. But like our stretchers are not made for the way that they probably are most comfortable breathing. So
Absolutely.
you may end up in a situation where
Yeah, it may be that it's too uncomfortable to sit them high enough
Yeah.
that is better for their respiratory drive. It may be that your stretcher's not wide enough that they can lean or move or lay a certain way. And so with these patients, BiPAP is a great consideration because sometimes in order to truly displace that weight that's on their thoracic cavity, you're going to need some positive pressure, but one that's comfortable, which implies BiPAP over CPAP.
So how do you make the decision when things are going crazy? Like, let's maybe set up a framework or an algorithm for our listeners.
So before we jump into how we're going to choose which, right? How we're going to go, do we use BiPAP? Do we use CPAP? Whatever it is. We can talk about if you even carry these things. So I know most services carry CPAP. Not a lot of services carry BiPAP because prior to recently, you needed a vent on your truck to be able to do BiPAP. But what do we carry instead?
We have the bi-level CPAP, which it works strictly on like portable main oxygen.
Mhm.
You don't have to have a vent for it, but it does allow you to switch over and be able to use, like they call it like a bi-level CPAP. So basically a BiPAP without a vent, which is really
So
cool.
Absolutely.
Your pressure is controlled purely on O2 flow, right?
Yes. So it's called the FlowSafe 2. It is a bi-level. So BiPAP is actually a proprietary term. Bi-level is the same thing. It's just like the generic term. But it works on mechanical mechanisms instead of just flow. And so you use the flow from your oxygen tank, and then that is going to adjust flow based off of certain mechanisms that are in the actual device. And it does both CPAP and BiPAP. The only thing that I wish it did that it doesn't do is that you can do an inline neb, but only in CPAP mode. You cannot do it in bi-level mode,
Yeah, that is kind of
which
rough.
is sad. But everything else has been super functional. We've actually used it a lot. And I have patients that I prior probably would have ended up having to RSI because CPAP would not have worked. Now we're bringing them to the ER improved,
Yeah.
which is super cool. So if you work for a service that does not carry a bi-level, just know that you do not have to have a vent now to be able to do it. And it has its limitations, but man, it is way better than nothing.
It's going to
Yeah.
reduce their need for sedation, too.
Yeah, absolutely.
It's definitely a step in the right direction, a low-cost solution.
Yeah.
Yeah.
So if you want to check it out, it is the bi-level FlowSafe 2, and you can see what. This is not a paid advertisement, by the way. And you can kind of see what that's all about. All right. So now that we know our options, how do we choose what we're going to use?
So the first thing you need to do is you need to identify where you're failing at. So is this an oxygenation problem? Is this a ventilation problem? A super easy way, and probably the first thing that you should do, is identify history. Like, does this patient have a history of an obstructive pathology? Do they have a history of CHF? What do their ankles look like? Are they fluid overloaded? And then obviously lung sounds are going to be a great indication. Do we have wheezing? Do we have rhonchi? Do we have global rails? Do we have unilateral rails? And then kind of going from there. Then you can kind of get into your more diagnostic tools, end-tidal CO2, which if you did not listen to last week's episode, you should, because we're very passionate about it.
Just a little.
And once you have done those steps and you can determine, does my patient need more oxygen? Then we're probably going to go a CPAP route. Is this a ventilation issue, right? So is my end tidal high? Are we a COPD or do we have asthma? Am I failing at a ventilation status? Then probably we need more support. So that's when you would go with bilevel. Just remember, fast and panicked usually means oxygenation failure. Slow and sleepy usually means a ventilation failure. Which, anecdotally, that is true.
Yeah.
Mm-hmm.
Yeah, once
Absolutely.
we've gotten to ventilation failure, we are giving up.
Right. And remember that, like any other pathology, you're really trying to figure out, like, chicken or the egg. Like, which one came first, right? Is our oxygen now low because our ventilation is trash? Or is our ventilation now trash because our oxygen has been low?
Yeah.
Right? So you want to figure out which one came first. And sometimes you can't. Your patient's that far down the tubes that we don't know which one came first. Unless you listen to their lungs and it's like...
Or nothing.
Or just silence. Then you may. But you kind of want to figure out which one came first because they can present simultaneously sometimes when you have patients that are, like, pretty far down.
Sure.
So if it's an oxygen failure, what do?
Like there's something in the way of them getting oxygen.
Yeah.
CPAP.
Right? If it is a ventilation failure,
BiPAP.
what if it is a oxygen failure that now, because they've been working so hard for so long, they're so tired that it's a ventilation failure?
Definitely.
BVM.
Definitely still BiPAP.
BiPAP.
BiPAP kind of always comes out on top.
Yes. I think
Early.
a good rule of thumb for me is that if it is an oxygen failure that has currently not compromised their ventilatory effort, we can go CPAP. Regardless of the etiology, if their ventilation effort is now compromised, we're going BiPAP.
I like that.
Yeah.
So next step, now that we've decided, is it what the main cause of their failure is, oxygen or ventilation or mixed? Now we can move on to our next question, our next step in the algorithm.
So step number 2 is going to be, can they protect their own airway? Any protocol, any time you learn this in school, you know that a contraindication of CPAP or BiPAP is an altered level of consciousness, right? So just some rule of thumbs. Can they keep their tongue out of the way? Are they able to cough? Can they handle their own secretions? Are they able to follow simple commands? If any of those are a no, then you probably are going to have to pull out some bigger guns and kind of, for lack of a better term, bypass these interventions.
For sure. And I also think it's important to remember that CPAP, your patient has to be willing to put in the amount of effort it takes to overcome the pressure.
Which is a lot of effort.
A lot of effort.
That's why, have you ever put CPAP on somebody because it's all we have and they get worse
Way
almost
worse.
like immediately?
Mhm.
That's why.
Because they do not have the energy to overcome the pressure. But which is something that I did not quite understand
And
when I
that
started.
is a fight I will have with people. Not actually, guys. I'm not fighting people, but a conversation I'll have because people will say, well, they weren't bad enough for CPAP. It's okay to do CPAP early before, if that's all you have. First of all, if you're trying to decide between a non-rebreather and CPAP,
It's CPAP.
it's CPAP, okay? So it should be
Yeah.
it should be a very early step, if that makes sense.
For sure. And I think that in my brain, if they are awake enough to handle a CPAP, they're like awake.
Yeah.
Right? I think that I am a little bit more lenient in my BiPAP application. Not that they are like literally unresponsive. But if someone is a little sleepier or I can tell they're getting tired,
Yeah.
and they're not necessarily head nodding, we're not to a point of an ultra level of consciousness that like we're big concerned about, but I can tell like their energy levels are failing.
It's a better option.
BiPAP for me is still appropriate.
Yeah.
Now, am I going to be more heightened to have a backup airway and a backup plan ready? Absolutely. But just remember that BiPAP does not take as much. It still takes energy, but not as much energy as your CPAP does. So even when you think you may be past a CPAP point, you may not be past a BiPAP point. So just keep that in mind.
For sure.
All right, so then step number 3 would be, is this patient hemodynamically stable enough to be able to handle CPAP or BiPAP? Like we already talked about, a relative contraindication is going to be hypotension, right? Because you're putting more you're affecting your preload, which in turn is going to affect your blood pressure. So you don't want to tank somebody that you already know is heading in that direction. So again, if that is something that you see, you need to go ahead and have a backup plan ready and know that you're going to have to pull out something bigger, or work on getting them hemodynamically stable enough to be able to pull the trigger on this intervention.
Absolutely. And can you do things simultaneously?
You can actually. Yeah.
Right. If you have a patient whose pressure you're concerned about, but they absolutely need CPAP or BiPAP, then you need to start working on both at the same time. So you need to start working on, well, we should already be working on access, but you need to start coming up with a plan to both support their hemodynamic stability and support their respiratory and ventilatory status.
This is where you pause and say, we're not ready to hit the road yet. I need my partner.
Absolutely. We have lots of things to do that we need to do at the same time.
Yeah.
You can set up your BiPAP mask without applying it.
Mm-hmm.
You can get fluids, pressors, whatever it is that you need to hang to be able to support that hemodynamic status to then apply your BiPAP.
Okay, but let's say that I want to apply a CPAP to a patient who is fluid overloaded. We're to the point where we are pulmonary edema, but we are decompensated to the point that we are hypotensive. Can I give this patient a fluid bolus? Question mark?
So controversial.
So controversial.
Yes.
Why?
Because where is their fluid, guys?
Their fluid
Ask
is
yourself that.
interstitial.
Oh my gosh, it's not in the vasculature anymore.
Yeah, our body can't use interstitial fluid. It can only use intravascular fluid. It's really similar to, like, you know, when people place a chest tube and a bunch of blood starts flying out of the patient's chest and everyone is like, oh God, and you get really uncomfortable. That is like, there's literally just blood flowing out of somebody, and inevitably someone will be like, clamp that. Clearly there's too much bleeding.
Yeah.
But like, why? Why would you clamp it?
You would not.
The blood is already
not
in the
do that.
interstitial space. It's not
Yes.
useful, right? So those patients, you still want to get rid of it because it's not useful to them.
It's going to cause other problems.
Yes,
right?
and so a fluid overloaded patient that is hypotensive, it is a very similar concept. The fluid that is still in their body is no longer useful. It is actually just in the way at this point.
Yeah.
But you still need interstitial fluid or intervascular fluid. You still need fluid in the vascular space to help perfusion.
And you might not give them Lasix in that moment, but you may
Mm-hmm.
give a 250 bolus. They're
Yeah,
not-
and we do not. A lot of
correct.
times these patients are very fluid sensitive, so smaller boluses are going to give you further improvement in their pressure.
Yeah, maybe don't go ahead and dump a liter of
Yeah,
fluid
don't do
in
like
them.
bilateral 18s with 2 liters of fluid.
Yeah, no.
Let's be responsible.
Yeah.
And with that, we are going to go ahead and cut this episode off. So much like how we talked about 2 devices, both BiPAP and CPAP, we're going to be cutting this into 2 parts. So stay tuned for part 2, where we break down some scenarios, the functionality of both CPAP and BiPAP, and some places where we may or may not use them. Yeah, so thanks for being with us, and catch you later.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.